Hello there, welcome to another session for the ST3 urology interview, and today we're going to do a history for an increased PSA. The questions usually comes such as a person has presented with lower urinary tract symptoms and the PSA has been noted to be elevated. They can give you any value, say 8 or 9. Sometimes people confuse the outpatient and emergency scenarios, and usually an emergency scenario will present as something like a very high PSA, like PSA of 1,000, 500 or 700. Whereas when it's outpatients, they will give you a value of somewhere in the middle, like 8 or 10 or something like that. And then you know that this is an outpatient scenario and not something like a metastatic spinal cord compression where you have to focus on the neurological history and the neurological side of things a lot and then speak to multiple teams. So this is basically the raised PSA in an outpatient setting scenario. You will usually know when you read the question for the outpatient scenario, it's quite obvious that this is an outpatient scenario. Okay, so this is an outpatient PSA history and this is how I would present it. As per NICE guidelines, I would like to see this patient in a prostate diagnostic clinic in the 2-week wait pathway, ideally with a prostate specialist nurse. I would read the referral letter and look for any previous PSAs or relevant investigations. I would check the patient's understanding and confirm their identity. I would then move on to taking a history. There's a lot of reasons for an increased PSA, but my most important differential is ruling out prostate cancer. In my assessment, I would risk stratify prostate cancer whilst ruling out other differentials. We'll take a focused urological history of lower urinary tract symptoms, including storage and voiding symptoms, and I will also ask for the onset, duration, and progression of these symptoms if they are present. I would ask for any associated infective symptoms and also the patient's sexual history. I would ask for any history of recent instrumentation, urinary retention, mountain biking, or other vigorous exercise, which can falsely elevate the PSA. I would rule out red flags, including hematuria, recurrent urinary tract infections, weight loss, anorexia, bone pain, muscle weakness, leg swelling, and any neurological deficit. I would risk stratify prostate cancer, taking in account the age, ethnicity, and family history of prostate cancer. I would then ask for any past medical or surgical history, asking about any previous TURP, baseline erectile and continence, and also any other neurological issues. I would ask for a history of anticoagulants, since they may affect if you're thinking about a biopsy, finasteride, since it halves the PSA, and tamsulosin, which indicates that the patient has pre-existing LUTs. I would also ask for any allergies, smoking history, general status, and performance status for radical treatment in the future if it is needed. I would also ask about lifestyle questions such as coffee, alcohol, tea, fizzy drinks, intake, etc. I would close the history asking about the ideas, concerns, and expectations of the patient. So this is how I would take a history of PSA. And then sometimes they would say, tell us how you would examine the patient. Sometimes if you're assessing them, you just go on telling them the examination as well. The examination isn't very long, so you can fill it in a line. Just say, I would like to then examine the patient in the presence of a chaperone and their consent, looking at general fitness and cachexia on general exam, on abdominal palpation, looking for any palpable percussible bladder, looking for scars and previous abdominal surgery, and do an external genitalia exam as well. I would then move on to doing a digital rectal exam, looking for number 1, size, number 2, features of malignancy such as hard, irregular, or craggy feeling prostate, tenderness, and also looking at the sphincter tone. I would do a neurological exam if there's any varying neurological symptoms. Say tone because, even though this is an outpatient scenario, it is good that you're checking the anal tone because they know then you're thinking about neurological symptoms, metastatic spinal cord compression, and things like that. Even though it's unlikely that if someone's got a PSA of 9 or 10, they will have that. But it's good to know that you're examining them thoroughly and this is your pattern and the way of examining patients. So this is all for the PSA station. We will discuss the questions in a separate station where we will go into details about what questions they can ask. All the best and see you next time.